Welcome back to the leading edge of integrative mental health. I'm your host, Lisa Dale Miller. Please review and subscribe to the Groundless Ground podcast on Apple Podcasts, Spotify, Stitcher, Google Podcasts, YouTube, radio.com, TuneIn, iHeartRadio, and of course find out more at groundlessground.com. I'm ready to go. How about you? Psychedelic-assisted interventions appear to be all the rage these days. And though there are many psychedelic evangelists, I wanted to find a credible medical resource to discuss these treatments. Deep gratitude to my friend Ron Purser, who introduced me to my esteemed guest, Sylver Quevedo, MD, a pioneer in integrative family and internal medicine, professor of medicine at Stanford and UCSF, co-founder of Polaris Insight Center for Ketamine-assisted psychotherapy, and principal investigator in the FDA clinical trials on MDMA for post-traumatic stress disorder. Our conversation taught me so much, and it was fascinating to hear about Dr. Quevedo's long history of work in public health, his devotion to providing medical care for indigenous populations in the American Southwest and Africa, and his enduring personal and professional interest in clinical use of psychedelic plant medicines. He beautifully explicates the biologic mechanisms of psilocybin, MDMA, ketamine, ayahuasca, mescaline, and how these substances differ in effect and usefulness in psychotherapy. Dr. Quevedo is limited in discussing outcomes of the current Phase 3 MDMA trials, but we do talk about results of previous trials, as well as the use of psilocybin-assisted psychotherapy for cancer, depression, and anxiety, and ketamine-assisted psychotherapy for suicidal depression and chronic pain. So sit back and enjoy the journey this amazing physician takes us on. Sylver Quevedo, thank you so much for agreeing to talk with me on the Groundless Ground podcast. This is, I think, going to be really interesting.
Well, I appreciate the invitation. It's always good for me to sort of break out of some of the standard modes that I talk about, this incredible phenomenon of psychedelic renaissance that's happening. People have more interest in it. And so it's important that we talk about it, I think, in various settings and to various groups of people.
So I actually want to lay some groundwork. Psychedelic-assisted therapy appears to be the thing, and lots of people are talking about it, but I don't think actually they have the wealth of experience that you've had, not only working with patients directly, but also clinical trials. You are an internist and have been one for many decades, and you've done lots of really interesting things, including integrative medicine. I want people to kind of get to know you first. Would you be willing to just talk about the journey that you had to becoming a doctor, and then the journey you had with plant medicines?
Sure. It's a long story because I've been a doctor for more than 40 years now. I was interested in biology and medicine even when I was pretty young. I also wanted to work with people, so I made a strategic turn. I was working in a laboratory at Berkeley, where I went to college, in a comparative endocrinology laboratory. I had a great mentor and professor, even as an undergraduate, Howard Byrne, who was an endocrinologist. So I decided to go to medical school instead of graduate school in biology. And it turned out to be good for me. Medicine, with all its challenges, requires some sacrifices, et cetera, to have as a career. It's given me a lot in my life. So I went to medical school right after college, then moved across the country to go to medical school at Harvard. Also sort of eye-opening because my background was very much in California and the American Southwest. My family is all from New Mexico. Also good in the sense that it broadened me enormously to experience the Northeast and the Eastern intelligentsia. During medical school, which was for me in the early 70s, family medicine was a new specialty, and there was a tremendous interest in expanding medical care for underserved populations. And I wanted to work in underserved communities and all that. So when I graduated from medical school, I went to the University of Arizona for internship training in family medicine, and I planned to do general medicine in community health centers, and I did that for 6 years after hospital training at the University of Arizona. I worked with several indigenous communities in Tucson in 1975 or so. And then I worked in community health centers for the next 6 years. For lots of reasons, I went back to training. One of the big reasons was that my kids were getting ready to go to school, and so I wanted to move back to California. I spent some time at the Stanford Law School studying law and public policy, and spent a little time with my kids for a couple of years, and then went back to training in internal medicine at Stanford, training in a specialty nephrology, and stayed on the faculty at Stanford for 12 or 14 years. When I was in primary care medicine, I became frustrated by the fact that a lot of what we were dealing with was not medical problems, but really the problems of poverty and inequality in our country. I also did a master's in public health at Harvard. And, when I was in specialty medicine, it was kind of the reverse. Everybody was very focused on the biology and the technology, which was fascinating, but they didn't seem to be too interested in treating patients as people. After a while, I got a little bit tired of that, and I had a sabbatical, which was an interesting turning point for me. I had a sabbatical at Stanford, and I was given an interesting opportunity. This was the mid-'90s, and Andy Weil wrote a book called Spontaneous Healing. A lot of us were sort of taken up with this idea of integrative medicine, which was kind of a return to whole person care, holistic medicine. Even though I was in specialty medicine, I sort of liked that idea. I also liked the idea that it had a kind of comparative approach to medicine. Integrative medicine was, at the time, one of the few areas where you could talk about Western scientific medicine as a type of medicine, not the medicine. Ayurvedic medicine, Chinese medicine, other types of healing traditions in the world were certainly respected. And I was drawn to that. A lot of my family is indigenous from the American Southwest, and ceremonial healing had always been important to me. And so I kind of held those things sort of personally, not professionally. When integrative medicine became something that people were sort of talking about and defining, I sort of turned to it, and I had this opportunity. I worked with a consortium of hospitals to investigate whether various models of integrative medicine, whether they could be used in community hospitals and how that would look and all that. I traveled to China. I went to India with a group of Ayurvedic practitioners, spent a month in Hangzhou outside of Shanghai at a Chinese medicine school studying Chinese medicine. During that period, I also went to work with indigenous healers of the Americas primarily at the time, both in the Southwest, Native American Church, for example, but also in South America, in the Amazon. And I worked with some ayahuasca healers. And that was literally eye-opening. During that time, one of the people that I was talking to was asking me, you've studied a lot of different healing systems. Have you come across any big medicine, like heart transplant? I said, yeah, ayahuasca. It definitely is heart transplant, but it's a much more sophisticated technology. There's not much blood and incisions involved, but it definitely opens up your heart. But one of the things I remember just sort of talking to you about it right now is that I thought, well, how is it that I sort of came through medical school and I've been in practice for almost 20 years and I never connected the idea of ritual, of ceremony, of mindfulness, of these sort of basic things that other traditions hold so centrally. I never connected that with healing. I did finish that study, and we wrote some stuff about it, and we did describe a model, and we did start an integrative medicine center at a community hospital and various other things. And I became involved with a lot of other people in the country at the time who were starting integrative medicine programs. When I came back to the division at Stanford, I had been gone only a year, but it seemed like the division had shrunk. I was on the faculty at Stanford in internal medicine and nephrology. I was running hemodialysis and peritoneal dialysis for the county hospital in San Jose. And so we were teaching very much specialty medicine. Coming back to it, the faculty meetings really seemed small-minded, overly focused on potassium flux, for example, and not enough on the obvious need for prevention. I actually remember one faculty meeting where I said, shouldn't we be doing more prevention rather than just putting people on dialysis? It's kind of too little, too late. And I remember one of the faculty turning to me and said, you want to do that, you go to general internal medicine. The short version of the story is I moved to UCSF to help start a program at integrative medicine at a new center, which was called the Osher Center for Integrative Medicine. I did not find it strange to talk about things with patients like mindfulness, for example, or spirituality, or some of the adaptations to chronic illness. I was much happier practicing a more integrated type of medicine. And I was also actively trying to learn from other types of practitioners around the world and in our group who practice Ayurveda, for example, or Chinese medicine, body workers, for example, the importance of human touch. It was hard to fit it into the academic medical center clinic, 15 minutes per visit. We were an educational demonstration project under the dean's office. We weren't part of the clinics with all their productivity requirements. So we were sort of protected. So I was able to see patients and spend an hour with each patient. We had Chinese medicine practitioners. We had Ayurvedic practitioners. We had some people that were cross-trained in both, that were Western MDs, but also trained in Ayurveda. We had nurses who were body workers. So it was an amazing group of people. And that went on for several years. I also worked to develop integrative medicine centers around the country and spent a little time at Duke University doing the same thing. After that, I did some consulting work in health IT. I had some friends who in integrative medicine who were really interested in some of the information technology that was coming along. And so we did lots of work in that area. I moved into the global health group. I came back to UCSF, but this time working global health, and spent the next 8 years primarily working in sub-Saharan East Africa, based in Nairobi. I lived in Nairobi for the most part for about 3 years and commuted there for about 8 years. And I was pretty much done with that part of my career and wanted to do some writing and a little bit of part-time practice. And then, the personal story is I have a son who I've been very close to my whole life. And he spent 15 years in the Navy as a submarine sailor. Came out of it so different, suffering from lots of post-traumatic stress disorder, from numerous things, not least of which is some real situations where he thought he would die and that sort of thing, which is the kind of thing that leads to PTSD. I realized I didn't know very much about it and about PTSD, and out of interest in trying to help him and work with him through some of the adjustments that are necessary and I think underappreciated in the transition from military life to civilian life, which is now such a phenomenon in this country because we've been at war for so many years. Anyway, I started getting in touch with people who were working on PTSD, and I knew some of the people in the MAPS world from prior experiences, including my experiences in South America with ayahuasca. And I was asked to come back to UCSF to renew my faculty appointment and participate in the MDMA trials. And that's what I did. And it's been very good for me, busier than I had anticipated. And now I'm part of the MAPS trial on MDMA in PTSD. And we have 2 sites, and I'm also part of the research group that will be starting. We're just starting actually this month, a study on the use of psilocybin for major depression. UCSF is getting together the beginnings of a psychedelic therapies research group. As you know, there's a tremendous amount of interest, not only in the neuroscience and some of the molecular biology and the clinical psychology and psychiatry, but also among the younger generation who are quite comfortable with these agents. Whenever I talk about MDMA, I never ask the medical students if they've used it because I don't want to sort of put them on the spot, but I ask them if they're familiar with it. And nobody ever says they are, but they usually all smile. At the faculty meetings, the nephrologists are afraid of it. They think MDMA is extremely dangerous, it causes seizures. And I said, a lot of that emergency room case reports and stuff are adulterated substances. A lot of the science that's been done on pure pharmaceutical MDMA, when used appropriately in the appropriate doses and all that, it looks to be relatively safe. Anyway, so that's in a nutshell sort of where I'm at now.
It's a beautiful history, and I'm so happy that you shared it, partly because these kinds of substances have history.
Yeah.
And the history has a lot of different threads. So obviously there's the indigenous histories, but also, for those of us who were teenagers in the 70s, we basically remember some of these substances as something you would never think of a doctor giving you. So I think people have a lot of ideas. So you used the term MAPS. MAPS is an association for psychedelic studies that's been around, it's got to be over 20 years now. I know my first access to them maybe was in 2002 or 2004. They really have been holding the torch for doing real good clinical research on some of these substance-assisted therapies for different kinds of disorders. Because you are such a great biology geek, I get to ask the wonderful question of, can you describe the differences biologically between MDMA, psilocybin, ayahuasca, LSD, and of course, now the most recent one people are looking at is ketamine. And there are many forms
Mhm.
of ketamine. Can you describe how they're different biologically, which neurotransmitters they actually
Mhm.
activate, and experientially, how that ends up being different?
There are a lot of different ways into that question and its answer. One of the ways that I like to introduce these substances is by the broad distinction that many people have used. And I should preface this by saying that, these agents, as you've rightly said, have been around in some traditional settings for thousands of years, like, for example, ayahuasca or peyote, but also in more modern settings, really since the 40s and 50s, the discovery of LSD, for example. And there have been people who are absolutely courageous pioneers who worked on these agents in a very systematic way. Stan Groff, for example, who did early work on LSD. Along that sort of broad sweep, and with a lot of that history, early on it was known that these agents had profound effects on people. Well, certainly expanding consciousness, altering consciousness, creating extreme kinds of experiences, etc. And so there was always a sort of question about what's going on here. In the early days, as you know, they were called psychotomimetic because they were thought to be an experimental model for schizophrenia. They induced a psychotic state. The best way of thinking of these agents really has come from Sasha Shulgin and others who like to distinguish two broad categories. Category of drugs of LSD, psilocybin, and dimethyltryptamine, for example. The so-called tryptamines or indoles, these have a certain chemical structure, and they work primarily on the serotonin axis or pathway in the brain. They have neurotransmitter properties. Serotonin, is a big deal in biology. A class of drugs known as SSRIs, or selective serotonin reuptake inhibitors, potentiate the effect of serotonin in the synapse, the connection between neurons. Serotonin has been called the happiness molecule, and it's not so straightforward as just sort of measuring serotonin levels and all of that, because these agents work at much different ways than other kinds of chemical mediators in biology. It's not just so straightforward as serotonin causes happiness, but suffice it to say that it's a very powerful neurotransmitter. And it has a well-known series of receptors, actually. But there's one in particular, the serotonin 5-HT2A receptor, which is a particular receptor in the brain, and seems to be one of the main mechanisms by which LSD, psilocybin, for example, can produce an expanded state of consciousness, imagery. They also have a unique property in that many people have transcendent experiences where they transcend time and place, they transcend materiality, they get in touch with their spiritual side and sometimes have mystical experiences and even experiences something that could be described as God or a transcendent power. And it's a common aspect of these agents. There's another category of agents like peyote, for example, or mescaline. MDMA is in this category. These chemically are not tryptamines. In organic chemistry or biology, they're referred to as phenethylamines. They have a phenyl group, which is a benzene ring, and an ethyl group, which is a 2-carbon side chain, more closely related to epinephrine or adrenaline or amphetamines. They're stimulants. So the phenethylamines are more like amphetamines, but the ones that we're talking about, namely MDMA and peyote or mescaline, have some side chain alterations. And one of the things we know from biology is that even minor side chain alterations, and by side chain alterations, I mean you can have the phenethylamine nucleus, the same nucleus as an amphetamine, for example, but substitute a hydroxyl group on one of the side chains of the nucleus. So minor side chain alterations can produce huge biologic effects. And the reason for this in biology is because many of these agents in biologic systems work in a kind of lock and key arrangement with biologic receptors. This is not the same as in chemical systems where really the laws of mass action more appropriately apply. In biology, you have the ability of a molecule to latch onto a very specific receptor and induce a series of reactions at the cellular level, which are very specific. And that's what we call biologic specificity. These agents, though they're related to amphetamines, and some amphetamines we know, for example, methamphetamine, are very toxic. And there's no question about that. Even though MDMA has some similar chemical features, it also has some differences, and those differences turn out to be very important. So we don't think that these modified agents are as toxic, for example, as others like methamphetamine. And we refer to that group of agents as attenuated amphetamines, or modified amphetamines, another term that's being used. But that category of drugs is mescaline, MDMA, MDA, in that they don't produce the imagery and a lot of the visions and the things that people typically associate with LSD, for example. Although some people can have minor psychedelic effects with them, more they produce what's called a heart opening or an enhancement of relational ability or communication. There's now more recent evidence to suggest that MDMA may be hooking into a system that's mediated not only by these effects on neurotransmitters, because some of the same receptors involved with epinephrine or adrenaline, for example, are activated, but also a series of hormones, oxytocin and prolactin, vasopressin, for example. And this system is now regarded as one of the most important systems that produces so-called prosocial behavior. What I was alluding to earlier on is that Sasha Shulgin and others, many years ago now, maybe more than 20 or 30 years ago, started referring to MDMA as an empathogen, something that enhanced empathy or the ability to understand and appreciate another person's feelings. The tryptamines as entheogens, or agents that induce an experience of transcendence, meaning, of spiritual importance. And I think that's a useful distinction. We see that a lot in the clinical setting with these agents. And if you ask yourself, how can those two experiences be harnessed to be useful in a therapeutic context, I think it's quite interesting to look at that. And sort of a quick answer to that is no question that MDMA can enhance the communication and the effect of therapy with a therapist, enhance the therapeutic alliance. And we think the way that that happens is that allows a deeper experience of safety and trust. MDMA appears to inhibit or stop signaling from the amygdala that activates the fight or flight system. Threat appraisal and experiences of prior traumas are changed during an MDMA session, and a patient can revisit a very traumatic experience, but without the flood of emotions that usually attends it. And this is hypothetical, but one of the theories is that experience allows for a reconstruction or a reconsolidation of memory. As one patient told me that after an MDMA session, he realized he was living with something that happened. He had experienced the death of his wife in a tragedy right next to him. For the next 20 years, that's the only way he remembered her. And after 3 MDMA sessions, said, it's the first time that he realized that was then, and this is now. And during that MDMA session, he went back to that memory, but instead of finding himself in that situation, he found himself about 4 years earlier when he had been with his new wife and had seen her sitting in a sports car that he had just bought and waiting for him. And he was approaching from the side. He stopped and looked at her and thought that she was the most beautiful woman in the world, and he was the luckiest person in the world to be with her. And he was just flooded with a sense of love and joy. He said, I realized that was then and this is now, and that's what I wanted to remember.
Before I lose the thread of this story, because a lot of clinicians listen to my podcast, the experience that patient had looking at his new wife in the car, this happened post the MDMA session. This was him not on MDMA. And so what I'm hearing you say is that it's not just that MDMA creates some kind of reconstructive experience in the therapy session with the MDMA assistance, but it has some effect afterwards in the person's life where they can have different kinds of relational openings. Is that true?
That's true. Part of the conventional dialogue that's going on is that these drugs are so powerful that they're probably best used with attention to so-called set and setting, a person's expectation and the environment in which they're done. It's not just the drug. And the trial that we're doing is called MDMA-assisted psychotherapy for post-traumatic stress disorder. So we're emphasizing, and I think this is right, and this is credit to the people who pioneered this research. Michael Mithofer, for example, a psychiatrist who was one of the early pioneers of MDMA research. This is medication-assisted psychotherapy. It definitely is psychotherapy, and that's important. And it's medication-assisted. And some of the psychiatrists are saying, well, that's really not new. We've had medication-assisted therapy in psychiatry years ago with barbiturates and various other things. And I'm sure that's true. But this is hopefully a whole level beyond some of that, which is sort of crude.
I think you just hit an oxymoron. Therapy and barbiturates together.
One of the benefits that I have is that I'm not a psychiatrist. So I have sort of a beginner's mind and I can ask all these naive questions of the psychiatrists with impunity. To me, medication-assisted therapy, the way we're doing it, was very new and very interesting. I've been around medicine enough, and I have a profound respect for talk therapy, much more than I ever have. But I also know that it can be really difficult and you can get into stuck places with patients. I mean, it can happen a lot. So to see these breakthroughs with medication-assisted therapy is just really wonderful. Therapists that I work with say, well, once you've done this, there's no going back. It's not that you don't do psychotherapy or talk therapy without medications. It's just that you know that it can be punctuated in various ways by a medication-assisted therapy session.
Somatic therapies say the same thing.
Same thing, right?
There's so many things that can happen that just can't happen with words. So yes, I'm used to hearing this and saying it myself.
I think that's great, Lisa. That's interesting what you said, because, it turns out that one of the most powerful releasers of oxytocin. So you know about oxytocin, right? Oxytocin is a hormone.
I do. This is the thing I find most fascinating about oxytocin. It's actually a connective hormone, but only for your in-group. In fact, for the out-group, oxytocin actually makes you feel less affectionate toward your out-group. So it's a very interesting chemical.
It's fascinating. So oxytocin is an octopeptide. It has 8 amino acids. It's a short peptide, very similar to vasopressin, comes from the posterior pituitary, etc. And well known in biology for its role in labor, in inducing contractions, its action in the so-called milk letdown reflex when a woman is lactating with a newborn. It's the bonding hormone. Early Fair to Thrive studies where newborns who didn't have connection with their mother just didn't eat and didn't grow. In men, it's possible to have oxytocin excess from a pituitary tumor in that. And internal medicine was always sort of a mystery in men. Like, what does oxytocin do in men? We had no idea for years. It wasn't very much studied either. When we first started doing integrative medicine, one of the things that I learned from somatic therapists like you was that human touch, especially in the middle portion of the back, is a very powerful oxytocin releaser, which is a fascinating idea. These are the kind of things that I think that came out of integrative medicine, which are so important. It's clear that oxytocin in men produces better behavior. And exactly what you said, there were some experiments were done where some people say, well, we just need to put oxytocin in the water supply. Everybody should have more oxytocin. They'll be more loving to each other. And so they did that. They put oxytocin in the water supply with some mice, and they were better to the in-group. They were worse to the out-group, right? So instead of just ignoring the mice from the out-group, they kind of murdered them and stuff. Commonplace to say that oxytocin produces ethnocentrism or excessive in-group identification, which is a fascinating idea. It's not so surprising in biology. We get used to thinking of physiology as having more cycles or an afferent limb and an efferent limb. So that something might do something, but there's also a countervailing hormone that does the opposite, or some other mechanism which produces feedback inhibition.
Let me double back again to your phenomenal description of the biology, which is so fascinating. I think I could accurately say that SSRIs are like a blunt tool. And even though they work on the serotonin receptor, it's not very targeted. When I first started looking at the biology of psilocybin, which was very interesting, I immediately saw that serotonin was very specifically being activated, but not bluntly. You know, psilocybin is a very specific experience. It's an experience of not just a sense of love, but it's not MDMA kind of love. It's not the personal love. Everything is transpersonal, a sense of going beyond that small sense of self and stepping into a way of experiencing humanness in its collectivity as well as transcendent. What do you think this serotonin action is actually doing that is so different in psilocybin and LSD from these blunt tools that we know as SSRIs? Don't even work that well for many people.
Right. Lots of side effects. SSRIs prevent reuptake of serotonin in the synapse. Whenever you're working in a biologic system and you have a continuous or chronic effect on a receptor system, there's an adaptation in biology that nature is smarter than we are.
Homeostasis is king.
Right. So you bombard a receptor with SSRIs for years and you have receptor upregulation or downregulation. In other words, the receptor is not quite as responsive after a while, right? And it makes sense in biology. You know, you're getting too much of one thing, so the receptor adjusts. The effectiveness of SSRI is well known to sort of wear off over time. A lot of these drugs, like SSRIs, as you're taking them every day, there's a lot of question whether that's a good model in psychiatry. And it's one of the reasons that medication-assisted psychotherapy there's so much excitement about it, because you'll do a medication-assisted therapy session once every 3 months or once every month, and the rest of the time, other things like massage therapy or exercise or talk therapy. So receptor biology is a real thing. The second thing is the mechanism of action of SSRIs is really on the reuptake mechanism. It's not on the receptor per se. Psilocybin is a direct agonist. So serotonin chemically is 5-hydroxytryptamine. It's a tryptamine nucleus with a hydroxyl group at the 5 position. Dimethyltryptamine is a tryptamine nucleus with 2 methyl groups on it. It's very close to serotonin. And psilocin or psilocybin, also very close. Again, this idea of a nucleus that's similar, but side chain alterations having big differences in effect. The main point is that those agents act just like serotonin. They're direct agonists. They don't work indirectly on the reuptake mechanism. So it makes sense that psilocybin, for example, would do what serotonin does as a direct agonist. And you would need a lot less of it because you're directly, hitting the receptor. One of the things you said was that what wasn't expected with some of the MDMA experiences, for example, was that these results are durable. They last after the session, sometimes for months. And that was a big deal in the MDMA research. But it's also true with the tryptamine. People in the end-of-life experience, they were given psilocybin with cancer and end-of-life anxiety. At Hopkins and NYU, and they had profound experiences that helped them cope with end-of-life anxiety, and people just took away. It's not that their situation was changed in any appreciable way, it's that they were able to derive meaning from their experiences in a much bigger way than they ever had been before. So their coping was much better with it. And a lot of it had to do with exactly what you're saying, the sense of being connected to something much larger, that their life and the importance of what they were going through was something much bigger, that they tuned into transpersonal and collective kinds of phenomenon. A lot of different ways to talk about that. This is a real renaissance in terms of research. What's happening in neuroscience is that the probes are incredible now. You can do a lot more chemical probing in terms of mechanisms. The nanotechnology is incredible what people have. I mean, they have microcircuits that are tiny, that can send signals implanted in the brain. It's amazing. The MRIs, functional MRI, PET scanning, etc. The ability to get a better view of what's happening on the biologic side in neuroscience is dramatically different in the last 15 years. And psychedelics are one of the most interesting probes to one of probably the profound scientific question of our time, and that is the nature of consciousness. The history of MDMA is that before it became illegal in the late 90s, it was well known in therapy context. It was legal, therapists were using it, and there was lots of positive reports, et cetera, about it improving couples. But the big surprise in the phase 2 studies, which were studies where patients are given MDMA directly, and there's no placebo control, there's no blinding, so they were given MDMA, and it was studied for safety and efficacy in this exact form as a medication-assisted therapy session. Those patients, after 2 MDMA sessions, this is for post-traumatic stress disorder, they had about a 60 to 70% improvement in their PTSD scores. So that wasn't so surprising. The big surprise was that 12 months later, follow-up studies showed that the effect was durable. Almost 70% improvement at 12 months that was sustained. No one expected that a couple of MDMA sessions would have an effect that would last for a year. That is what led to designation as a breakthrough therapy by the FDA, and is what paved the way for phase 3 trials, which are now being conducted in 13 centers across the U.S. and is a randomized, double-blinded, placebo-controlled trial.
It appears as though psilocybin-assisted therapy is being studied for use with end-of-life, cancer in general, depression, not so much with anxiety yet. And MDMA, those studies mostly are around PTSD. Did I get that right?
That's right.
Okay. Ayahuasca and LSD and DMT, these substances are not being studied clinically.
Yeah, it's a great question and sort of interesting too. One of the reasons that I was taken by ayahuasca is that it has a pre-scientific history. It's been used in the Amazon basin. Their estimate's 3,000 years, and it has a whole culture associated with it. And there's a lot of variation in regions, in Colombia, Brazil, Peru, and some variations in the various sort of subcultures. The Santo Daime, for example, which is more a syncretic type of religion, opposed to some of the traditional indigenous use, and some tribal variations as well. But there are some features which are common to all of them. And one of them is that ayahuasca is regarded as a sentient being. It is a plant who is a teacher. And the very first time I heard that, I worked with an amazing person. And there are a lot of people in the ayahuasca world who are just like doctors. I mean, there's good ones and bad ones, the whole thing. This ayahuasca healer was a beautiful person who really was wise and kind and a real healer. His name was Pablo Amaringo, and I worked with him. And the first time I heard that, that the plant is a teacher, I thought, wow, so there's a source of wisdom in the world that is like not human. That's definitely going to be an improvement in my world to learn from another source. I was really taken by that idea. I have to say that my early ayahuasca experiences, I really did have this encounter with a sentient being. I remember one time I was drinking ayahuasca with a friend of mine in South America who was a psychiatrist. And he was kind of a scientific guy. He said, okay, I have this sort of question. I'm going to ask ayahuasca, okay, if you're really like a sentient being, then are you telling me these things or are the things that are happening, are they just happening in my mind? And this is all part of my mind doing its tricks. So he's like, is this you or is this my mind? And so the next day, I said, hey, did you get an answer to the question? He said, yeah, I got a very direct answer, but it wasn't very helpful. I said, wow, so you actually got an answer? And he said, yeah, I said that exact question. It was like an experiment, right? And the answer I got was, that is all about you. That has nothing to do with me. Ayahuasca said, that's your hang up, has nothing to do with me. That question is all about you. I thought, wow, that is brilliant.
Ayahuasca is a Buddhist teacher, obviously.
Exactly, right. Exactly.
This is what your Rinpoche would tell you.
It was fascinating. One of the things that intrigued me was that these agents in a traditional setting have a long history in practice. So I was interested in, how do these healers work? What do these agents do, et cetera, et cetera? And so one of the principles is that the plant is a teacher, right? There's another part that is also common to all of the ayahuasca traditions, and that is that a lot of the songs and prayers. So a traditional ayahuasca ceremony is a healing ceremony, but it's also a prayer ritual. It's a prayer ceremony. In North America, in the Southwest, a lot of Native American rituals, like the Beauty Way ceremony. So one time someone said, well, what had you found in your travels in integrative medicine that stands out compared to what we do in Western medicine? And I remember this because I said, it would be inconceivable to give a medicine in a traditional setting without a prayer. And in Western medicine, we would just never even think of that. And then actually, that's probably one of the reasons that mindfulness in conventional practice is important. And in fact, Herb Benson, some people at Harvard, so they were doing a small series of people just as they were getting induced for surgery. And, modern surgery is a ritual. You're
Yes.
being put in a very unusual situation with absolutely no control and being given mind-altering substances that are powerful, that may kill you, and you have to trust the situation. So modern surgery is the epitome of a modern healing ritual, but it's not approached with any attention to its spiritual aspects. And, there's a long trajectory of this in the theologic literature, et cetera. But anyway, so Benson was doing this trial, and they were experimenting with people writing out affirmations for their surgery and then standing next to them while the anesthesiologist is going to give them their drugs and repeating the affirmations. And one woman, he was standing there with her, and he said, well, you want to go through your affirmations, we'll center ourselves and sort of be mindful. And she said, I would like to pray for my surgeon and my anesthesiologist. I would like to say how grateful I am to them for who they are and what they're doing, and that they have a good day, because I know that's going to be good for me. Benson, he said he felt a little choked up because it was so profound. This person who's going to have an operation, instead of thinking about themselves, they think about their surgeon, because it's going to be hard for the surgeon too, right? So there's kind of a generosity in this. Really, the person who got the most out of that prayer was the anesthesiologist, who was sobbing by the end of it. So what I took away from that is that everybody, not just the patients but the doctors too, can learn a lot.
Not to switch gears, because this isn't actually a gear switch, it's along the same line. Although different, you are co-founder at Polaris Insight Center, where you are actually delivering MDMA as well as the psilocybin-assisted sessions. But one of the big things you're doing there is ketamine-assisted psychotherapy. Not only are you doing individual sessions, but you also have group ketamine-assisted psychotherapy. Yeah. What form of ketamine are you using at Polaris? How is it being administered? For what kinds of mental health maladies are you prescribing it for?
A great question, and interesting in a lot of different ways. In San Francisco, we had a lot of MDMA MAPS-trained therapists, but not that many physicians. I am part of the UCSF group, where I'm not a principal investigator. At the UCSF side, I'm a study physician and a therapist, actually. I sit with people when we give them MDMA. At the practice site, and I have the MDMA license, I'm the PI. And that's one of the great things about San Francisco. There are a lot of people who are trained and interested. So we have a fairly active activity in San Francisco compared to the other sites in the country, which usually have one site per city. The MDMA trial is for severe PTSD. A lot of people who have PTSD have either what we call complex PTSD, or they have PTSD from more than one episode or trauma. And a lot of people have PTSD and other things like depression or substance use disorder. They don't qualify for the trial. So a lot of people who wanted so-called trauma-focused therapy, or therapy with people who were trained to deal with PTSD. We were in touch with lots of people, including some of the pioneers of ketamine-assisted psychotherapy, Phil Wolfson in Marin County in San Francisco, Jillian Andrews, who worked with him, some of the people who pioneered ketamine-assisted psychotherapy, which is what we call it. And ketamine has a long history. It was used in the 60s, et cetera, in various settings, and also has interesting psychedelic properties. What's different about ketamine, it's a legal drug, and it's been used in hospitals as an anesthetic for almost 30 years now. When I was at Stanford in the early 80s, I was a normal volunteer in a ketamine study where ketamine was given intravenously. So I had a 3-hour ketamine infusion as a normal volunteer. So it was kind of an amazing experience. So it was fascinating. My friend was doing the trial, and he said, look, we need some volunteers. You want to be a volunteer? I said, sure, I'd be interesting. After an hour of ketamine, the thing I remember was that I was in the top corner of the room looking down at my friend who was taking my blood pressure and myself. And I remember this to this day vividly, saying, if I'm up here, who is that down there? I had this epiphany that consciousness survives bodily death. And that was my only experience with ketamine. When we set up the program, Phil Wolfson and others had been using ketamine in very much similar way that they really invented, called ketamine-assisted psychotherapy. So ketamine, it's a drug that has unique properties. It has anesthetic properties, and it's a so-called dissociative anesthetic. So it sort of disconnects your body from your thinking mind,
right?
Which is kind of a weird idea. It produces what is quite well known to psychologists, the phenomenon of dissociation, which is where you're sort of like not there,
Mm-hmm.
right? And something that happens with trauma. And the reason it's a big deal in medicine is it's the only anesthetic agent which produces sufficient anesthesia to do procedures like to do incisions and various things without suppressing brainstem function. So it doesn't depress respiration or heart rate or any of the brainstem functions except at very high doses, and even then minimally so. So it's a preferred agent, for example, if you have to intubate somebody with a lot of laryngeal edema, like a burn victim. You don't want to suppress their respiration without getting a tube in first, but you can't get the tube in because they have so much laryngeal edema. Or in infants or children who have a small airway, it can be hard to ventilate them. Ketamine is a legal drug whose safety profile is well known and clinical use is well known. Along that way, it's been known in hospitals to produce in some patients the so-called ketamine psychosis, which is where people have psychedelic experiences at a given dose. And in hospitals, it was regarded as an undesirable sort of side effect, and it was treated with benzodiazepines. So someone sort of, sees God or something like that, and you say, oh, that's ketamine psychosis, and you give them Ativan. The doctors didn't really pick up on that. Well, there were other, I think, more reflective souls among them, like Phil and others, who said, well, wait a minute, this may be a psychedelic phenomenon that could be useful. And that's what led to the emergence of the so-called ketamine-assisted psychotherapy, where ketamine is used at lower subanesthetic doses to induce an altered state of consciousness. And it's a little different than the other psychedelics. It's much shorter acting. It's very safe in the outpatient setting. Well, this has been going on for about 10 years or so, but in the last 6 or 7 years, a lot more research is done. And suffice it to say that ketamine is now considered the drug of choice for acute suicidality. If someone is very suicidal, ketamine can be life-saving.
How would you administer in that case?
In that situation, it's been studied primarily intravenously, and there's a whole lot of history about that. Part of the reason that IV ketamine is used in these settings is that it's quite familiar to anesthesiologists. So it's a drug model. They don't necessarily do therapy with it. But that's a whole different category, and we don't do that. We just don't like the idea of medicalizing it or just making it a medication thing. Ketamine can be used sublingually or buccally in the mouth. It can be used intranasally, and it can be given intramuscularly and intravenously. The difference is that the bioavailability of each of those routes is different. You give it in the mouth, it's about 30% absorbed. In the nose, it's about 50% absorbed, and intramuscularly, about 95% absorbed, and IV, obviously 100% absorbed. In general, it's a short-acting substance that can induce a psychedelic state, and it's different than the other psychedelic agents. It's different than the tryptamines. It's more dissociative state, and the altered state that people experience doesn't have a lot of the organic beings and colors and that of the tryptamines, but it is an altered state. I think many people experience an empathogenic effect, and it does have antidepressant properties. Usually transient, usually lasting for 2 or 3 days. With repeated dosing can lead to a more durable remission of depression. And that's the current focus of a lot of research. And this is a whole other topic. Mental health services and availability in this country is a disaster.
Yeah.
3 broad categories that we treat: the trauma survivors or PTSD category. There are the anxiety syndromes, which are quite common, and then depression. And ketamine is a little bit different for each one of those. Certainly useful for depression, not as predictably useful for anxiety, but can help, and the same for PTSD. And the reason it's a special category, it's chemically different than the tryptamines or the phenethylamines, not like MDMA, and it's not like psilocybin. It's a different pathway, the glutamate pathway. Probably has some effect on the hippocampus and memory consolidation. So there may be some similarity in mechanism there, although different than what MDMA does. It's not understood, and it's a very active subject of research. I can just say in clinical practice, it's been very safe. We only do IM and sublingual lozenges. When done in this way with therapy, it's been very safe. And I think one of the exciting things for me is, in the sense we're reinventing therapy. People have a more supported opportunity to engage in therapy and deal with problems with mental health, with or without concomitant medical problems. We have some of the ketamine patients we're treating are patients who have cancer and are at end of life. The reason that we're using it is that it's legal.
The thing I don't understand is, over the years when I work with people who have unremitting depression, it always seems to me that the best kinds of treatment that work for them are treatments that are connective. Because there's such a lot of distortion when you have depression, the isolation, the feeling of this is only happening to me, that sense of there's no aliveness in the system. So, the kinds of things that I've done for my patients is increasing actual physical aliveness in the system through different kinds of somatic techniques that we use to get their libido and healthy aggression back in the system. And part of that treatment is always allowing them to recognize the dorsal vagal collapse, which is just so chronic in these patients. Ketamine is a dissociative, and dissociation is part of the dorsal vagal system. It's one of the things we do to seek safety. So I have this conundrum in my mind. How can something that induces dissociation lessen the depressive response, which is such a dissociative response? It makes no sense to me whatsoever.
I mean, it's certainly not only you that's asking that question. Absolutely. I mean, our case conferences, we have this sort of round and round, some patients, particularly PTSD or trauma survivors, dissociation is a comfort. That's where they live. It's a comfort zone for them. It's also one of the reasons they have trouble in relationships. Give them ketamine, they'll go there. One of the things we notice, they'll come back with some of the other effects of ketamine, pleasant and all that, but no content.
Right.
So some people say, gosh, if you had your druthers, you wouldn't use ketamine. You'd use MDMA or psilocybin, right? Ketamine wouldn't have a place. And this is a raging debate because there are definitely people who believe that ketamine has its own special place and its own special properties. Clearly, for some people, dissociation is not therapeutic. It's a place they go in order to avoid feeling, addressing certain kinds of things. There is a way to use ketamine at lower doses, which people refer to as psycholytic, where you have lower dose ketamine sessions, you're not fully dissociated. So you actually do talk therapy with ketamine. But for others, you're right. I don't think it's the right agent. In addition, we have had patients in exactly the opposite situation who have chronic pain. For example, one of the patients we had was a 35-year-old who was an Olympic skier. I mean, he was like a big time, and he had like a major accident with some incredible 10 surgeries on his back and these special things that they made to put in between his vertebrae. Anyway, this guy had been in chronic pain for 5 years. He never had a day without pain and had a lot of secondary depression, couldn't do his life. I remember this vividly. We gave him ketamine and he sort of sat up at the end and he said, I haven't had a pain-free day in like 5 years. And this was such a gift. It can give people a glimpse of what it's like to feel better, sort of get in touch with what Benson used to call remembered wellness. I think there is a place for it. It is not necessarily right for many people, and it's a different kind of psychedelic experience. It's much more non-dual. If ayahuasca is a plant teacher, kind of nature is sacred, and that's the world that it lives in. What is ketamine? Well, ketamine is sort of like the Tao. Whatever you say is, it's not, and it's very abstract. Probably as a physician, I'm saying there's probably some role for it. It's just not for everything. The difference is that it's legal and it can be used now. And for many, the induction of an altered state is a completely new thing. So it is one of the ways that you can introduce someone to an altered state of experience.
So are you suggesting that the dissociation has analgesic properties for someone who has experienced chronic pain every day for 5 years?
I wouldn't put it that way. I'd say that the drug has anesthetic properties. It works by dissociation of cortical experience from the body.
Just so the listeners can really be clear about what you just said, because it's very, very important. With ketamine, there is a cutting off of the communication between the physical system and the brain in some way, so that the pain signaling lessens.
Right.
It's not that they're in a psychological dissociative state. And I think this is a very important distinction.
I think that's true, and that's the type of anesthesia that it produces. Having said that, it can also induce a kind of dissociation in the psychologic sense, and if that's counterproductive for a patient, it's probably not the best choice of agent. Many people who go to IV ketamine type experiences without the therapy, and we get a lot of patients that have been through that and prefer coming to us in order to do this with or without ketamine. So we don't think ketamine is good to give without therapy.
To be clear again, because most of the ketamine sites, particularly ketamine sites for chronic pain, where there's an anesthesiologist or there's a physician that's just doling this stuff out, there is no
therapy going on. People just go in for their ketamine.
There are a lot of places like that, and maybe there's more therapy now starting to happen in some of those places than used to be because people have been sort of raising this. There are many physicians who are using ketamine who really regard it just as drug effect. We just don't think it's the best use of ketamine. It's not to say that ketamine can't be used specifically for pain control, etc. We had one patient, interesting, who had a frozen shoulder, a lot of chronic injuries to the shoulder, but was also depressed. We gave him ketamine in the ketamine-assisted therapy model. And he started moving his arm around a lot for the first time in years, as if he had had anesthesia. As he was doing that, he was saying, yeah, I still have a lot of pain, but he was obviously freely moving his arm, and his expressions of pain were inconsistent with the movement. And we actually had this whole discussion in our case review, because when he came in, if he moved a certain way, he would say, yeah, that really hurts. But this was a dissociation between his physical movement and the experience of pain. And we said, wow, is it possible that we separated out the physical component of his suffering from the mental component? Fascinating. I don't know that that's been well characterized, but I think that it's possible the two can be fused in a person's experience and that they wouldn't even know that they're different until something like that would happen.
We have this experience, those of us who are trained to deliver very specific awareness practice to chronic pain patients, where they actually learn how to rest in the coming and going of the actual sensations they're having. And it very quickly becomes apparent to them the story they have about what the pain is gets disambiguated from the sensations themselves. And when they rest in the sensations themselves, all of the bracing in the muscles and the tissues loosens because they're not defending against this series of incredibly interesting phenomena that are coming and going. And it's completely disconnected and disambiguated from the horror story that the mind has actually created by habit about that pain sensation. So that without the story, the sensations are kind of interesting. The level of pain goes down in their direct experience. The way of thinking about their quote unquote chronic pain completely changes when they do this more and more and more. I've been trained for so long in contemplative practices. And because I've been delivering these contemplative practices to patients for many years in targeted ways, when I hear you describe what's happening with these beautiful plant medicines, it causes me to think, well, obviously the receptors are there. The brain knows how to produce these things on its own if it has the right way to do it. It doesn't necessarily need to have some external drug. And so much of it sounds so similar. I mean, you can ask long-term meditators, what happens if you're sitting for 2 hours? Why are you not feeling your bodily pain?
Yeah.
And it's because they're doing a targeted attention practice where the mind is so collected that it's cut off pretty much all of the experience except maybe thalamic experience, which actually feels very oceanic, sitting in the ocean of consciousness without a self, because all you've got is brainstem and thalamus.
Right.
I'm just finding this whole conversation so beautiful because not everybody is a contemplative practitioner.
Right.
To give someone a psychedelic-assisted therapy session where they could have this incredible ego-loosening experience would be enough to really shift the way the ego is experiencing, for instance, depression and the idea of isolation and aloneness in the world when there is no such thing ultimately.
In the ketamine clinical literature, there is a phase that's referred to as an ego dissolution. People completely lose a sense of self in the narrow sense, begin to experience this sort of pure mind or consciousness at large. And some people experience it as a death experience, and it can be frightening. But definitely there is this sort of ego dissolution. I remember talking to a psychologist about this, and I told him that one of the experiences I had that I noticed with ketamine is it's sort of like I had this knowing, being awake or conscious, but not myself, but not confined. And he said, yeah, sort of pure mind. And I said, the crazy thing that I remembered from that experience was that I had this feeling of love or joy, but there were no objects. It was completely blank, no objects. I said, so it's the strangest feeling to feel this sort of love without objects in the field. And I was asking him as a psychologist, he said Ramana Maharshi talked about that.
Well, yes, of course.
And then he sent me this book of Ramana's teaching.
Mhm.
And there's a section where it says the ground of being is experienced as the benevolent universe. It's a kind, loving universe.
It's true. In the Dzogchen teachings in Tibetan Buddhism, the ground of being, or kunji, that's the Tibetan word for it, it is the union of clarity, capacity to know, and emptiness, which is interdependent arising of all phenomena, and kunji itself. The union of those two things in its expression, because the ground of being is beyond anything that's manifest. When it has expression, its expression is compassion.
Wow.
The entire purpose for the manifestation is compassion. Ground of being could not be anything other than the openness, completely open-hearted. Everything can come.
Beautiful.
Nothing's left out.
I have to sit with that one for a few minutes. That's beautiful. A lot there. Clear mind, yes, but in the service of a loving heart.
And in actuality, that clarity is not separate. Manifestation from the clarity is the compassion. It would naturally be experienced as this unbounded open-heartedness.
That's great.
The wisdom teachings, it doesn't matter which tradition they are from.
That's right.
Including plant medicine teachers.
Mm-hmm.
It's all the same, right?
Right.
If we could only get viruses on board. Bacteria are kind of cool.
Right.
We actually need them. We can't live without them. I don't know, viruses.
It's been a nice reprieve from all the coronavirus stuff I was living with all morning. Gosh, what a phenomenon.
I'm sure, like me, you've been doing your sessions by Zoom the way we're doing it right now. I can't imagine you're actually delivering the substances in this way, are you?
We're not doing any MDMA sessions right now. All of our clinic visits are telemedicine. And although some of the therapists are experimenting with at-home sessions with ketamine lozenges, which are a little bit lower dose, and using Zoom because some patients have trouble without regular therapy.
This has been such an incredible conversation.
I regard this conversation that we're having in the broadest sense of the word as really important for this. And I've enjoyed hearing your thoughts on it as well. When I was working in Africa, I was working with a lot of people from all over the world and very different sort of experiences and models of reality. And we actually came away with an idea that dialogue itself may be the epistemology of our time. We're experiencing this pluralism that we've never seen before. It is important to do this in the broadest sense. There's a lot more, but I think this has been great.
Do you have any recommendation for the clinicians listening if they're interested in finding out more or in getting trained?
For the MAPS trials and the MAPS work, the MAPS website is great, and it's easy to find online. The registered clinical trials for MDMA and psilocybin are clinicaltrials.gov. The Polaris group is really a great group of therapists. The thing is that we've gotten pretty busy, and right now we're respecting the stay-in-place order, so we're doing everything like video. There's not much more activity than that happening there. I would encourage people to take up these discussions. Maybe if I had to leave people with one thing, the power of these substances is enormous. They should be respected. And I don't want to be prudish about it, that, they can be enjoyed and all that, but I think they're so valuable in a therapeutic context that they shouldn't be casually wasted recreationally.
I'm really glad you said that. And I agree with you 100%. Plant medicine is powerful, like lots of other medicine, but used out of context, I don't think it's as valuable.
Yeah.
Well, thank you so much.
Thank you. I've enjoyed it.
Thanks for listening to today's show. To get in touch, please visit groundlessground.com. Let's dedicate our efforts to the healing of our planet and all its inhabitants. See you next time on the Groundless Ground.